So I'm going to talk today about bleeding, which does seem a bit strange, seeing as I'm a menopause specialist talking about bleeding, and the definition of the menopause is when bleeding doesn't occur. But there are lots of people that do have bleeding, so I thought I'd just talk about it for the next half an hour or so. So during the perimenopause, as many of you know, the perimenopause is the time when periods start to change in nature or frequency and menopausal symptoms start. And it's due to our hormone levels reducing, but they reduce in a very chaotic way. So when we have nice regular periods, our hormones are in balance with each other. So we get a surge of estrogen as when we ovulate, and as you know, the second half of our cycle, our hormone levels become very low. And when our progesterone especially, but also estrogen reduces, it leads to a withdrawal bleed. So what happens is the lining of the womb gets shred because it's built up in the first half of the cycle. That's if a woman doesn't get pregnant, of course. And that shredding of the lining of the womb leads to a period. Now in the perimenopause, hormone levels are quite chaotic, so it means there will be times when estrogen levels are higher, which leads to more stimulation of the lining of the womb, and progesterone levels might drop a bit quicker, or they might not be as high, meaning that the lining of the womb gets shred at different times. So a lot of people think that in the perimenopause, people's periods become lighter, they become less frequent, they become more scanty. That might occur, but actually we know that lots of women have the opposite. So their periods can become heavier, they can become closer together, and they can last for longer as well. So there are lots of changes that can occur. Now, I never realised this when I was younger, doing my gynecology training, doing my GP training, or even working as a GP. And I've already said before that the perimenopause can last 10 years or so before the menopause. And the average age, not that anyone's average, but the average age of the menopause does actually mean that most women in their 40s will be perimenopausal, or they might be menopausal already if their periods have stopped and they've had a menopause at an earlier age. As you might know, 1 in 30 women under the age of 40 have an earlier menopause when they're younger. So that means there will be women in their 20s and 30s that will be perimenopausal and not realise it. Or they might have symptoms related to PMS and PMDD when hormone levels fluctuate, and these people are more sensitive to hormones. But that can still alter periods. So there can be lots of hormonal reasons why periods can change. Women with PCOS, for example, polycystic ovarian syndrome, it can be related to an imbalance of hormones. And a lot of women with PCOS find that they have less frequent periods, but when they do, they can be very heavy. As many of you know, endometriosis can cause painful, heavy periods as well, and periods can be irregular, and there can be hormonal changes in women with endometriosis. So lots of reasons why people can, if you like, naturally get heavy periods. We know that the best time to start HRT is actually during the perimenopause, when menopausal symptoms occur, when hormone levels start to fluctuate. And I've already spoken quite a few times before about it can be quite difficult knowing the right dose and type of HRT to start when someone's perimenopausal. Now, we're all different. Our hormone levels are changing all the time when we're perimenopausal. And some people, it's the progesterone that drops first before the estrogen. And I know some people have asked, and thanks for your questions, by the way, there have been loads, but I have read them all. Some people find that their progesterone drops sooner, and you get this relative, and I'm talking relative because I don't really like the term of estrogen dominance. And so some people find that they can get quite heavy periods that can be closer together, or they can be very persistent. And sometimes that can be due to the progesterone dropping quicker than the estrogen. And sometimes we find actually just giving progesterone to people can make quite a difference. And then with time, the estrogen is of course going to decline and stop or really lower. And that's what happens obviously during the perimenopause and menopause. And so sometimes with women who are perimenopausal, they don't need much estrogen to try and regulate things and try and improve their symptoms. And so that's why it's really important to see someone who understands that HRT isn't a one size fits all. It's not just giving the same dose to everyone and seeing what happens. So in the perimenopause, hormone levels are fluctuating, they're tending to reduce, but they can be very chaotic. And this chaos can cause a disruption, if you like, to the lining of the womb, which is called the endometrium. Now, the lining of the womb builds up, like I say, and then shreds, causing the bleeding. But if hormone levels are sort of chaotic and a bit up and down, it can really confuse, if you like, the endometrium, and that's why this bleeding can occur. When people start HRT, we normally do give estrogen as well as progesterone, but like I say, sometimes we do give progesterone first and add in estrogen, or sometimes, not very often, we start estrogen. If someone's having very regular periods, we might start a very low dose of estrogen and then add in progesterone after a few months. Everyone's different, so this is all very general advice, of course. But we know that when we start HRT, when women are perimenopausal, so they're still getting bleeding, whether it's irregular or regular, we start HRT in what's called a sequential way or a cyclical way. So what we do is we give estrogen usually all the time. So every day someone has estrogen. The best way of having estrogen is through the skin as a patch or a gel. And there is a spray, but we find that it's not very reliably absorbed. So usually the patch or the gel every day is the estrogen. So the gel gets applied every day, the patches get changed twice a week. And then the progesterone is the cyclical bit. So we usually give it for 2 out of 4 weeks. Now, usually if someone starts their period, we call that day 1. And then 14 days later, so usually half the way through the cycle, we say start the progesterone. Now, most women don't have 28-day cycles, and so it can be very difficult to know and count. But usually we just say take the estrogen for 2 weeks, continue with the estrogen, so you're taking it all the time, and then take the progesterone for the second 2 weeks. And so usually the progesterone, the best progesterone, as many of you know, is the micronized progesterone. So it's the same structure as the progesterone we produce when we're younger. It's just been micronized, so it's put into like a fine, so it's sort of ground down almost, so it's micronized, very small, and it's suspended in some oil so it can be absorbed properly. So usually that's taken at night time, because one of the side effects is it can people can feel a bit drowsy, so it can help them sleep. And people usually take 200 milligrams at night orally for 2 out of 4 weeks. Now, it can take sometimes a little while for periods to settle down. So a lot of times when people start taking HRT, especially when they're perimenopausal, their periods can be quite irregular. They can be more irregular than they were before they started HRT. They can be lighter, they can be heavier. It really does vary. But what we know is that the first 3 to 6 months, you don't know what it's going to be like, and it usually does settle into a pattern after 3 to 6 months. So I always warn people when I start giving them HRT that they might have bleeding, it might get worse, it might be very unpredictable, it could be light, it could be heavy, but after 3 to 6 months there's usually a pattern, and so the bleeding does normally settle down. I do see quite a lot of women who have had horrendous bleeding, really awful, and they've found it really difficult to be offered any treatment at all. We do sometimes give something called tranexamic acid, and I know someone asked about this. Tranexamic acid just reduces some of the bleeding. It's not a hormonal treatment, but it can be given with hormones quite safely. So if we give the progesterone in a cyclical way, so 2 out of 4 weeks, some people, certainly those that have very heavy periods, often find that their periods become a lot lighter, a lot more manageable, and a lot more regular. So even just giving HRT in that way, one of the first things that people come back and say, wow, my goodness me, my periods are so much lighter, so much easier to manage, which is great. the periods that people get on HRT are not the same as the sort of natural periods. They are a bit like when people are on the contraceptive pill and have like a withdrawal or bleed, because the lining of the womb gets shred when people have progesterone. That's how progesterone works. So if the estrogen has built up the lining of the womb, then the lining of the womb is shred when people take the progesterone, and that's what happens. So when people are perimenopausal, they're still having periods, we usually, and there's never 100% in medicine because everything is very individualised, but usually we start the HRT as a cyclical way. So we give the progesterone for 2 out of 4 weeks. Now it's confusing because the progesterone is actually licensed for 12 out of 28 days. I presume it must be people that don't have periods that were sitting around a table deciding the 12 days, because no one wants to count their days and it doesn't really make sense. So we usually just say 2 out of 4 weeks, so 14 out of 28 days. If you want to make it really easily, start counting at the first of the month and do it for 2 weeks then, but usually people just get into a pattern. Now, there's lots of women who have messaged me and said, well, how long do I keep this cyclical HRT for? And so usually, and again it's a usual, we do it for between 6 and 12 months. When women start to have a quite nice pattern to their periods and they seem to be on the right dose and type of HRT, then often I will convert them into what's called a continuous type of HRT, which essentially means you have the progesterone every single night. When the progesterone is there all the time, it doesn't really allow the lining of the womb to build up, so therefore there's nothing to shred. So usually when people have a continuous type of HRT, it means that they shouldn't have periods. Now, that can take a little while for that to settle. So say, for example, I've seen someone in her 40s who's perimenopausal. I give them HRT, so maybe a patch with 2 out of 4 weeks of Utrogestan, and then I see them again, usually see patients after 3 or 4 months, find that symptoms hopefully are improving, they're starting to feel better, and then usually I'll say, well, carry on for another 6 months or so, review the lady, and then if she's feeling fine, I might say, well, firstly, do you want to continue having periods? Now, most of us, the best thing of the menopause is not having periods. There are some women, especially younger women, who quite like having their periods. So it's no harm to carry on with this cyclical HRT. There's no reason why you can't. It's just actually better to have the lining of the womb thin, to not have periods. But if people want to have periods, that's fine. So most women then I would convert to and say change, carry on the estrogen the same, and then have the progesterone every night. It is actually licensed for 25 out of 28 days. But again, for most women, that doesn't really make sense and you don't want to be counting days. So you can just take it every evening. And then I always say you need to really wait 3 to 6 months when you've had the change before you know that your periods are going to stop, because any change in HRT can cause a bit of disruption. The body can be a bit confused, you can get some side effects, or you can get some bleeding, and bleeding is the main reason why people stop taking HRT. So persevere, but if people are still having irregular bleeding, if it's quite chaotic, maybe slightly heavy, then it might be because they're producing their own hormones as well. And so then what we normally do is say, go back to the cyclical HRT for another 6 months. It might be too early to convert to a continuous. So that's the first thing that we do if someone's having this irregular bleeding on HRT and they've been on a cyclical HRT. We've tried to convert them to the continuous and the bleeding's carried on, then we usually say go back to a cyclical regime and then see if a pattern goes back to how it was before. If it does, then it's unlikely to be anything else to be concerned about. So if people start on a continuous HRT, so say I've seen someone in my clinic who's 53, she hasn't had a period for 4 or 5 years, wants to start HRT because she's having symptoms, so then I would normally give the estrogen as a patch or gel, so continually, and then give the progesterone orally at night, and this time it's half the dose, so it's just 100 milligrams at night orally in a continuous way. Now, even though she hasn't had periods for a few years, I will always warn her that she may have some breakthrough bleeding, she may have some bleeding, it might be heavy, it might be light, it might be irregular, might even be continuous. And the bleeding can occur for the first 3 to 6 months of starting HRT. It can be quite alarming if you've not had a period for quite a few years and then suddenly to have some bleeding. But it's usually just related to the hormones stimulating the lining of the womb and a reaction, if you like, to the HRT. So if someone has started HRT and had some bleeding within the first 3 to 6 months of starting their HRT, then they don't normally need investigating unless there are any other symptoms, or it's very heavy or persistent, or someone feels unwell, or they've got other symptoms that they're concerned about. Then obviously go and get checked out. But usually we say that bleeding within the first 3 to 6 months of starting HRT can be quite common. And it's worth persevering because it does normally settle with time. So what you don't want to do is just suddenly stop your HRT because you haven't given it chance for things to settle down because you've had the bleeding. So if people are warned about it, then it's definitely easier to persist with if you do have bleeding associated with taking HRT. Now, it's not always Intrauterine that we give. A lot of you, I'm sure, will have heard of the Mirena Coil, and I know many people ask questions about the Mirena Coil, and I have spoken about it before. The Mirena Coil is a very small coil that goes into the womb, and it contains a synthetic type of progesterone. So it's not the body identical progesterone, but it's very, very low dose. And what it does is it works onto the lining of the womb and keeps the lining of the womb very, very thin. Therefore, there's no bleeding. So most people don't have bleeding when they use the Mirena Coil. Now, the Mirena Coil can be used as part of HRT for 5 years. So once it's in, it can stay for 5 years. And I have many patients who come in every 5 years and just have their Mirena Coil replaced because they like it, it suits them. Then they don't usually need to take the progesterone. When people have the Mirena Coil put in, whether they've been having bleeding or not, more frequently actually if they have been having bleeding before, it can cause some bleeding. You can imagine if there is some small build-up of the lining of the womb, the Mirena Coil goes in, the lining of the womb shreds, therefore there's bleeding. And so bleeding can occur, and it can be quite alarming once you've had a Mirena Coil. You think, well, I've had it to try and reduce my periods or stop bleeding, and now I'm getting bleeding, and it can be really frustrating. Again, we always say 3 to 6 months. We used to say, years ago, I used to say 3 months, but I've been caught out so many times. And actually, the recommendations are wait for 6 months. And I've literally seen so many women who've been bleeding on and off for 5.5 months, get towards the 6-month mark, and then their bleeding settles and it stops. And then they have no periods at all for 4.5 years until the Mirena needs to be changed. And they might or might not have bleeding when they have the 2nd, 3rd or 4th Mirena. So the Mirena is also a contraceptive, which is really good. So for people who are perimenopausal, as you might know, HRT is not a contraception. So if you're perimenopausal, you're having heavy periods and you need contraception, then the Mirena Coil can be really useful. I have spoken to a lot of people who say, my doctor's given me the Mirena Coil and says that will sort out my perimenopause. It absolutely won't, because it hasn't got estrogen or testosterone in it. It's only got the progesterone part. But I've already said the progesterone part is firstly synthetic, and it works very locally on the lining of the womb. It's a very low dose. So there are some people who enjoy the benefits of progesterone. I've already said progesterone's an anti-inflammatory hormone. It goes into our bloodstream, it goes all around our body. It can be very calming on the brain, it can help with sleep, it can help reduce anxiety, it can help build bone strength, it can be good on our cardiovascular system as well. So some people might have been on progesterone before, have a Mirena Coil put in because of the heavy bleeding, and then are advised to stop the progesterone and then feel worse. And you can take progesterone with having the Mirena Coil because you're taking it for the beneficial effects for it to being a systemic hormone. Some people are told that they can't have both. Well, I've already said before, there's nothing in medicine you can't have both of, but actually it does make sense because the Mirena only works locally on the womb, whereas the progesterone will work throughout the body. Now, I've already said the Intrauterine is usually given orally, but I have said previously to people that it can be given vaginally off licence as well. When it's given vaginally, it stays as the pure progesterone. It gets absorbed through the mucous membranes of the vagina into the bloodstream and is the pure progesterone. When it's taken orally, it gets metabolised. So it means actually you can get a higher concentration when used vaginally compared to orally. As an alternative to the Intrauterine, the soft gel-filled capsules that we take orally, there is other like vaginal pessaries. So there's one called Cyclogest, which is made for the vagina, which you can insert actually vaginally or rectally, and either way they just get absorbed as the pure progesterone. That's all it contains, is the pure progesterone. Because you get a higher concentration in the body, and it's the pure progesterone. Some people who find that they still have bleeding with the tablet type or the oral capsule of progesterone, taking it vaginally can actually be really effective of reducing the bleeding. And sometimes we give a slightly higher dose if people are having bleeding. And you might think, oh, I don't want to put something up my vagina when I'm bleeding. But actually, if you can get over that, using it vaginally often stops bleeding quite a lot quicker than having it orally. So it's just an option. Obviously, you need to be advised by your doctor. And then there are other types of progesterone that we sometimes give orally as well. Obviously, I've already said the body identical progesterone is preferable, but the synthetic other types of progesterone, they're in the progesterone-only pill, they're in contraceptives, we know they're safe, they just don't have the same biological effects in our bodies. But there are some people who find that they bleed more and have more breakthrough bleeding with the Intrauterine than they do with the synthetic progestogens. So I've got quite a lot of patients who have troublesome bleeding. I know it's related to their HRT, and so I will give them the synthetic progesterone, maybe just for a few weeks or sometimes for 3 months. And then it seems to calm down the lining of the womb. They don't have bleeding, and then after about 3 months they can convert into having the natural progesterone back, the Intrauterine back, and that works very well for them. So there are always options, which is good. Now, not every type of bleeding is due to the HRT. Of course, there are other reasons why people get bleeding, and I've said at the beginning, people with endometriosis, but also adenomyosis, which is similar to it's similar to endometriosis, and you get some sort of lining of the womb tissue actually growing in the womb, in the muscle part of the womb, and it can cause pain, it can cause bleeding. And I see a lot of women who start HRT, find they get painful bleeding, we arrange a scan and then find that they've got adenomyosis, which they probably had before but hasn't been diagnosed before. And so one of the treatments will be using a Mirena coil, can be very effective. Now, there are other reasons for bleeding, so people can have polyps and or fibroids as well, and these are non-cancerous, but they can cause troublesome bleeding. So if people have bleeding which comes out of the blue, so it's been more than 3 to 6 months after starting HRT, then we always recommend to have an investigation. So usually a doctor will examine somebody to make sure that there's nothing visually that we can see. We often use a speculum, a bit like when people have a smear test, have a look into the vagina, look at the cervix, look at the surrounding tissue, make sure there are nothing there that's obviously causing bleeding. Sometimes people can have infections that can cause bleeding. Sometimes people can have symptoms related to genitourinary syndrome of the menopause, and so people can have bleeding even if they haven't got a womb. It sounds a bit weird, doesn't it? But not all bleeding comes from the womb. So obviously we can check people, and then the first investigation we normally do is a pelvic ultrasound scan, and we're very fortunate in the clinic. We have someone who's really, really good at scanning and can have a really good look at the womb, at the ovaries and the lining of the womb. And what they often do is look at the lining of the womb, see if it's smooth or if it's irregular. They'll be able to see if there's any polyps there or any fibroids or anything else or any thickening of the lining of the womb. And they usually measure what's called the endometrial thickness. And this can cause a lot of confusion, and different areas have different levels of thickness, so it can be quite confusing if you're told you've got a thickened lining of the womb. Now, because women have estrogen that we know does thicken the lining of the womb, not all thickening of the lining of the womb is dangerous. And it's what it looks like on the scan, but also the actual thickness too. What we always want to not do, obviously, is to miss if someone had a cancer of the lining of the womb. So if we just go back in time, when they started giving people HRT, they actually started just giving estrogen, and they found that some of those people had bleeding. When they were investigated, some of those people, a small percentage, had thickening of the lining of the womb. We call that hyperplasia, which just means it just means hyperplasia means growing too much, really, of the lining of the womb. And a very small percentage of people with hyperplasia had cancer. And so then what they did was say, right, we'll give progesterone as well, and that reduces the risk of cancer of the lining of the womb. And we know from studies that if women take progesterone continually, so every single night, then their risk of cancer of the lining of the womb is lower than people who don't take HRT. So that's very reassuring. So if people have some thickness of the lining of the womb and they're on HRT, then unless it's really thick or looks abnormal, it's likely to be related to being on the HRT. The problem is that when people are older and have bleeding, they have this referral pathway called postmenopausal bleeding, and it's a sort of fast 2-week referral in case there's a cancer there. So if I was a 60-year-old woman and I'd not had a period for 10 years and I wasn't on HRT and I suddenly had some bleeding, then my risk of endometrial cancer would be greater than if I was a 60-year-old woman and had been on HRT for 15 years in a continuous way and had some bleeding. But unfortunately, the guidelines don't determine whether you're postmenopausal and never been on HRT, or if you're a postmenopausal age but you're still on HRT. And so it can be really frustrating for the gynecologist, because they're seeing a lot more women who are having bleeding, because a lot more women, there's about 1 million more of us, that are now taking HRT than used to be. So the gynecologists see a lot more people who are bleeding. Now, if you have got bleeding and you've been referred for a scan, which is a very appropriate investigation, you don't need to stop taking your HRT before having the investigation, because it doesn't actually make sense. What they want to do is see what the lining of the womb is like when you're taking HRT. And I've done a really good and informative podcast with Osami Naji, who's a real leader in scanning. He's a gynecologist in London, and I'll put a link afterwards so you can have a listen if you want, and he's very clear as well. So if you're on HRT and you've been referred for investigations, you don't need to stop taking your HRT before the investigations. If you're someone that's having the cyclical HRT and you're still having periods, it's always better to have the scan when you're having your period or just after you've had your period, because that's when the lining of the womb will be at its thinnest. I've seen a lot of women who've been told, oh, the lining of your womb is slightly thick, you need to have a biopsy and a hysteroscopy, but actually when they've had their scan repeated after they've had bleeding, the lining of the womb becomes thin. So it's worth it being interpreted in clinical context. If they find when they've done the scan that the lining of the womb is thickened and it reaches or is beyond the threshold of normal for that department, then what they often do is recommend a biopsy to have a look at the tissue to make sure that there's nothing abnormal that needs treatment at all. So it's certainly obviously worth going down that pathway if need be. So one of the questions was a lady that had been referred for a hysteroscopy and said, I've been told I need to stop my HRT for 10 days before. Again, there doesn't really seem to be any sense for doing that. So normally you can continue taking your HRT. Often when women have some bleeding and they're on HRT, quite a few women say to me, well, it feels a bit like a period. I've had some breast tenderness beforehand. I felt a bit bloated. I felt a bit irritable, a bit like my period's coming, and then I've had some bleeding. Just lasts for a few days and then I'm fine again. So that isn't really a bleeding that I would be particularly concerned about. Sometimes what happens is when people start HRT, it sort of gives the ovaries a bit of a rest, and then the ovaries have a bit of a they just squirt out more hormones in a chaotic way. And so certainly that's, if people feel sort of hormonal as well as having bleeding, it's more likely related to hormones than anything serious. Cancer of the lining of the womb often causes a continual bleeding that happens all the time. It's usually bright red blood, and it's usually persistent. I say usually because there are always going to be exceptions, and it's always better to err on the side of caution. If you're concerned or your doctor's concerned, then certainly the first thing we would do is offer an examination and refer people for a scan. And the ultrasound scan doesn't contain any it's not an x-ray at all, it's not painful, it's very easy to do. So that is something that we would often consider doing. Now, I've already said when people have had a hysterectomy, they've had the womb removed, then it's quite unusual to have bleeding, but you can have bleeding from the vagina, the vulva, the surrounding tissue, so always get checked. There are some people who have had what's called a subtotal hysterectomy, and subtotal means it's not complete. So what they normally do is leave the cervix behind, but actually on the top of the cervix there might be a bit of the lining of the womb tissue that's still there. And some people can bleed from there if they've only been given estrogen, because I've already said estrogen can stimulate the lining of the womb. So if there's a little bit of the lining womb left, you can get some bleeding from it. And so what we normally do is give people what's called a progesterone challenge. So we actually give people the progesterone for a couple of weeks after 3 months of having estrogen to see if they bleed or not. And if they do have some bleeding, we recommend to continue with the progesterone. So if you've had a hysterectomy, it's always worth checking, is my cervix left behind or not? Most people it isn't, but it might be, and if it does, then you might need to have progesterone as well. So that's just something to think about. The other thing to say is if people are getting heavy periods, then often we do an iron level as well, a ferritin level, and ideally it should be above 75. I see a lot of people whose level is 30 or 40, and the printout just says normal, but actually you want it above 75. So if you are having heavy periods, it is worth asking to have your iron level checked as well, in case you need iron too. The other thing to mention is that sometimes people are absolutely fine with their HRT, but then maybe they've been on holiday, or they've forgotten to take their progesterone for a couple of days, or maybe they've been putting on sun cream and they forgot to apply the gel at the same time, or there might be a time difference. If there's any disruption to your HRT, it can cause some bleeding. So one of the first things that I do if someone's bleeding, I will ask, has there been a change in your HRT? And certainly when there were shortages, there were a lot of women that say, oh yes, I changed to a different patch and it didn't stick on very well, or I changed to the gel from the patch, or I forgot to take the progesterone for a few days because I went away and I didn't pack it. So that can always trigger some bleeding. You can imagine if you've got estrogen continually going into the body from a patch, and then the patch doesn't stick very well, or it's not changed on the right day, it will disrupt the amount of estrogen going to the body, which can cause a bit of chaos to the lining of the womb. So if that happens, then we usually say carry on with your normal HRT that you normally do and see if the bleeding stops. And if it doesn't stop, obviously we can consider an investigation, but if it does stop, we don't need to worry. So a lot of it is working closely with your healthcare professional. So I hope that's been helpful. I realise it's lots of information. I'm going to put a post to on my story with some links for podcasts and some information, written information that we've got as well about bleeding on HRT. But like I say, it's one of the commonest reasons why people stop HRT, which is a real shame, because when you get the dose and type right, and sometimes it is altering the dose or the formulation of the progesterone and the balance of the hormones before we get it absolutely right and you don't have bleeding. So I hope that's been useful, and look forward to seeing you next week. I'll put this on my grid now as well. So thanks very much.